Sir, with all your permission, we are live. Can we begin?
We can start.
Thank you so much, sir. Good evening, everyone. This is Vatil from IGCP, and I'd like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. Well, sir needs no introduction at our platform, but it's our pleasure and honor to introduce him. He is none other than the very renowned cardiologist, Dr. Keshavamurthy CB, sir. Sir is MD in General Medicine, DM in Cardiology, DNB in Cardiology, and consultant at Manipal Hospital, Mysore. So with sir's help, we'll be talking about today's topic, which is heart defects, aortic valve stenosis, atrial septal defect. So before moving on to today's session, let us have a brief look on what the topic says. Heart defects such as aortic valve stenosis and atrial septal defect are structural abnormalities that affect the normal functioning of the heart. Aortic valve stenosis narrows the aortic valve, impeding blood flow from the heart. ASD is characterized by an abnormal opening between the atria, causing blood to flow between them. These conditions can lead to various symptoms, including shortness of breath, fatigue, and heart palpitation. So we'll be learning more about the diagnosis and appropriate management strategies, crucial in providing optimal care for individuals with aortic valve stenosis and atrial septal defect with sir's wonderful input. So now without any further delay, I would like to welcome sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Sure. Thank you all. Thank you very much for this kind invitation. And thanks for the opportunity to talk to you all. And thanks to all the participants for sparing that time to be here. So since this is an ECG talk series, I'll be talking about the ECG markers of these two defects today and will be very brief. Maybe you're all waiting to see the Chandrayaan landing on the moon, so I'll finish before the Chandrayaan lands there. So the first defect, first topic of the day is atrial septal defects and how we diagnose them based on the ECG. What are the ECG markers? When we look at various structural heart diseases, including valvular heart diseases, septal defects, congenital heart disease, they all produce ECG marks or ECG signs of the defect as a surface electrical representation. That means when the heart has an underlying defect, whatever defect, the ventricular septal defect, atrial septal defect, tetralogy of Fallot, transposition of the great arteries, Epstein's anomaly, all these have certain peculiar appearances on the ECG. From the ECG itself, we can suspect or sometimes diagnose that this patient could have an underlying congenital heart disease, or what is the type of defect, what is the pressure in the ventricles, everything can be detected from the ECG alone. In fact, before echocardiography came into existence, there were several electrocardiologists who used to see ECGs so expertly that they were able to predict the size of the ventricles, which ventricle is dominant, and all these based, the pulmonary artery pressures used to be predicted without any invasive parameters at all. Those were our ECG grades, including Paul Wood and all. So today we'll see these two conditions and what ECG findings are there in these defects. Atrial septal defects can be of various types. You all know they can be ostium secundum, which is the mid part of the atrial septum. They can be ostium primum. I'll show you a small diagram to understand that. Sinus venosus defects, sometimes the defects may be multiple, and the interatrial septum may look like a seed where there are multiple small holes, and complex ASDs, which are associated with congenital heart defects. So ASD is a part of many of the syndromes, especially the cyanotic congenital heart diseases, where sometimes ASD is the only pathway for blood to mix, as in transposition of great arteries, where survival is dependent on mixing of the blood at the atrial level. So we can have fairly simple ASDs, which are the ostium secundum ones, and very complex ASDs associated with congenital heart disease. So these are the various types of defects. Just to orient you, this is the superior vena cava, inferior vena cava. This is a picture of the right atrium, which has been opened. This is the position of the secundum ASDs, right in the middle of the interatrial septum. This is the interatrial septum, and this is the mitral valve. The primum ASD sits right astride the atrioventricular valves. So that is the primum ASD. This is the secondum ASD. This is the IVC type of sinus venosus defect. And this is the type of SVC type of sinus venosus defect. So these are the various types of ASDs. Of course, there is a kind of ASD known as deroofing of the coronary sinus, where the coronary sinus opens there and its roof is absent, giving rise to a left to right shunt, exactly like a ASD. So this is a clinical picture of how ASDs look anatomically. And what are the changes produced by them? Whenever there is an atrial septal defect, we all know that there is a left to right shunting because the left atrial pressure is high. A lot of blood is moving to the right atrium depending on the size of the defect. If it is a small defect like a patent foramen valve or a small defect like 5 millimeter or 7 millimeter, the size of the shunt is very small. Small ASD, the heart is normal. There is no structural abnormality as such apart from the hole in the heart. There is no atrial enlargement, no ventricular enlargement, no change in the pressures. Usually the shunt is less than 1:1.5. That is the pulmonary, systemic to pulmonary blood flow ratio is 1:1.5 or less. Moderate and large defects, when the ASD is of the size of 10 to 20 millimeters or larger than that, then all the problems occur. The right atrial and right ventricular volume overload occurs. Then gradually, after a period of time, pressure overload occurs due to development of pulmonary arterial hypertension. In the later stages, suppose ASD is not diagnosed and patient is not treated, patients can develop signs of pulmonary hypertension, atrial fibrillation, right ventricular failure, and then the condition may become indistinguishable from other heart conditions which cause heart failure. So what do we see on the ECG? This is a classical ECG of atrial secondum septal defect, secondum type of ASD. You see that the axis is towards the right. In lead 1, there is a deep S wave. Patient is still in sinus rhythm. So there are some STD changes which may be due to RV strain, or patient may have additional systemic hypertension or whatever. You see a very dominant R wave in V1, which is again indicative of a right ventricular dominance. There is an incomplete right middle branch block. You can call it so because S1, and there is a small Q in lead 3, and the R wave is very dominant in V1. So rightward axis, sinus rhythm, and a large R in V1, all indicative of right ventricular hypertrophy. So like I said, the height of the R wave in V1 predicts the pulmonary artery pressures. Usually, if you calculate the sum of the squares here, it's about 5, 10, 15 squares. So about 5 into 5, minimum pressure in the pulmonary artery will be about 25, the mean pulmonary artery pressure. So that is how indirectly they used to calculate the pulmonary artery pressures before the cardiac catheterization came into existence in the 1960s. So what are the associated conditions and ECG abnormalities in ASD? Atrial septal defects are generally associated with mitral valve prolapse, incomplete right middle branch block, right axis deviation like I showed in the ECG. The primum defects are associated with mitral regurgitation. Like I said, the primum defects sit right on the atrioventricular valves and therefore produce cleft in the anterior mitral leaflet with varying degrees of mitral regurgitation. In this type of ASD, there is left axis deviation. The usual ASD, the common ASD which we see the secondum has right axis. But if you see a patient with an ASD and a left axis, you should suspect that patient has primum ASD. Sometimes there is extreme left axis deviation, which is called northwest axis, and first degree AV block because the conduction system also get involved anatomically in the defect, and it has to go around the defect to reach the ventricle. And first degree AV block is a common finding seen in about 75% of the patients with ostium primum ASD. In sinus venosus ASD, which I showed the picture earlier, usually most commonly associated with anomalous pulmonary venous drainage into RA or into the vena cava, and rhythm may be abnormal. Here you can have junctional rhythms or low atrial rhythms because of the defect. So let us see some more ECGs of ASD. Here you see what is commonly called as the crochet sign, where there is a notching of the R wave in inferior leads. If you see such notching, 1, 2, 3, in 2, 3, and AVF, if you see that, an incomplete RBVB-like pattern, an RSR dash pattern in V1, you can suspect that this patient can have a ASD. About 2/3 of patients with ASD, ostium secondum ASD, have the crochet sign, which common and a very popular sign which has been described in ASD patients. In addition, there will be right ventricular dominance, somewhat rightward axis, not exactly in this ECG, but you can see right axis deviation in most of the patients with ASDs. So this is what is the Crochet sign in atrial septal defects. The inferior leads show notched R waves. If you see the R wave here is normal, you see here there is a notch on the descending limb of the R wave. The same is seen here, 2, 3, and AVF. So that is called as the Crochet sign. So Crochet sign is seen in 2 weeks after closure of ASD. Crochet sign disappears in approximately 50% of the patients, but many of them, even after device closure or surgical closure, continue to have that as a form of mistake. Involves all 3 inferior leads in about 1/3 of cases. Involves at least 1 inferior limb lead in about 73% of patients. You can also see it in other defects, like in BSD, involves at least 1 inferior limb in 35%, less than in ASD, involves all 3 inferior leads in 2% of the VSD patients. So most commonly, the Crochet sign is seen in ASD. It's also seen in a small percentage of patients with pulmonary stenosis. So it is an important sign. Whenever you look at the ECG, if you see a crochet-like thing in the inferior leads, if you see that notching, you should suspect that patient has a ASD. It may not be always true because that can occur in interventricular conduction defects, some localized conduction system disorders that can mislead you, but you can predict that there could be a possible ASD and conduct an echocardiogram to confirm or deny the diagnosis. So now we'll see the primum ASD. Here you see that in lead 1, the S wave is negative, and in AVF also it is either 0 or negative, indicating a leftward axis. So whenever you have a patient with an ASD and a leftward axis, you should consider a diagnosis of primum ASD. The P wave is enlarged, indicating right atrial hypertrophy because of the left to right trend. Invariably, in atrial septal defects, the right atrium get enlarged. So that's why you get a prominent P wave, which is seen in V1 and also in the inferior leads. Also note that AVF is predominantly upwards as compared to lead 1, indicating right axis deviation. Left axis deviation with RSR dash in V1 is suggestive of primum defect. RSR dash is seen and tall R wave indicating right bundle branch block and right ventricular hypertrophy. You see that the dominant wave is the R wave. Instead of having a deep S wave in V1, there is a R wave, which all suggests a right ventricular dominance. So this is another patient with an atrial septal defect. Here you see that the patient has developed a atrial fibrillation. One of the long-standing problems of defect which is ignored or not treated, and when patients present above the age of 50 years, is patient develop rhythm abnormalities, which is one of the reasons for treating patients up to 50 years of age. Otherwise, there is no benefit of treating patients who are beyond 50 years with an ASD. Only reason is to prevent paradoxical embolism and development of atrial fibrillation. So this is a rhythm abnormality purely due to the right ventricular volume overload, and in later stages, the pressure overload due to pulmonary hypertension. So like I said in the last class, the rhythm is fast, it is narrow and irregular, and it is a sustained rhythm. Whenever you see a fast, narrow, irregular tachycardia, you can close your eyes and say it is atrial fibrillation. So that is about the ASD. Now we'll see briefly for the next 10 minutes about ECG in aortic valve disease. What are the changes produced by aortic valve disease on the ECG? We know that aortic stenosis is a disease whereby the aortic valve is narrow and doesn't allow the left ventricular ejection to come into the aorta, thereby producing increased pressure in the left ventricle. The left ventricle has to pump with higher and higher force to overcome the obstruction at the aortic valve level. And aortic regurgitation produces volume overload. These two conditions are usually mixed, and they produce a mixed overload with both pressure and volume overload pattern. In course of time, the stenotic valve degenerates and develops various degrees of regurgitation. If patient's disease course is complicated by infective endocarditis, that can produce moderate to severe regurgitation sometimes. So there is a mixed overload pattern. So we'll see what are the changes that are reflected on the ECG based on this. Since aortic stenosis, aortic valve is ejection of the left ventricle. Obviously, left ventricle is the one which suffers most of the damage, and for a long time, if the aortic valve disease is ignored, patient can develop congestive heart failure, pulmonary hypertension, And then those pressure changes can get reflected onto the right ventricle also ultimately. But the initial changes are on the left side of the heart. The left ventricle, to overcome the stenotic aortic valve with hypertrophies, it increases the thickness of its musculature, then the pressure changes are transmitted to the left atrium. So you will have left atrial pressure overload, left atrial hypertrophy, left ventricular hypertrophy. Then the rhythm abnormalities which are associated with aortic valve disease, which we'll briefly see in the next few ECGs. So like in any mild disease, ECG continues to be normal. Like in a small ASD, small VSD, no structural changes may occur in the heart, at least obvious structural changes. And therefore, the patient can have a normal ECG for several years when the disease is mild. In moderate to severe valve lesions, invariably some changes develop because of the higher pressures and higher work activity of the ventricle. We commonly see left atrial enlargement, left ventricular hypertrophy patterns, which are common to both systemic hypertension and aortic valve stenosis that you have to distinguish by using echocardiogram. Patient can have bundle branch blocks on the ECG axis deviation, left axis deviation, and atrial fibrillation, like in ASD. Atrial fibrillation also is a late feature of aortic valve disease, untreated aortic valve disease. Another peculiar association with aortic valve disease is development of complete heart block, especially when aortic valve annulus is calcified. The calcification can extend into the conduction system, thereby producing AV blocks. Sometimes after surgical replacement of the aortic valves, or now the new procedure after transcatheter aortic valve implantation, complete heart block can occur and patients may require pacemakers in anywhere between 2 to 10%, depending on the type of valve and type of pre-existing disease of the conduction system and the distribution of calcium around the aortic annulus and its extension into the left ventricular outflow tract. So these in summary are the changes on the ECG in aortic valve disease. So we'll see some of the ECGs. So what are the atrial abnormalities and how do we diagnose atrial abnormalities on the ECG? In the normal ECG, in lead 2 and V1, these are the two leads we see commonly for diagnosing atrial abnormalities because those are the leads which pick up the atrial activity or the P wave in a proper manner. So this is the normal pattern. The P wave is fairly symmetric, and in V1 it can be inverted or it can be biphasic, and both the limbs of this biphasic P wave are equal. In right atrial enlargement, because the initial activation, the initial part of the P wave is contributed to by the activation of the right atrium, you see that there is a tall peaked P wave, and the second part of the P wave is somewhat normal, like in this. So in V1, there is a sharp pointed upstroke and the P wave may be biphasic or it may become isoelectric. So in left atrial enlargement, they can have pattern like this. It is called as the M shape. This is the right atrial contribution. This is the left atrial contribution. Since the left atrium is more enlarged, you see that the left atrial bump is taller and also the P wave has become wider. The total duration of the P wave, total activation of the right atrial mass plus the left atrial mass makes the P wave look longer and its shape becomes M-shaped. And it is definitely biphasic. The negative portion becomes deeper than 1 millimeter and wider than 1 millimeter. So that is called as the left atrial index, which also is described as a sign on the ECG. So if you see such abnormal P waves, you can certainly diagnose right atrial enlargement. In biatrial enlargement, you see a combination of this when both the right atrium and left atrium are enlarged. Like I said earlier, in the initial stages of ASD, only right atrium is enlarged. When patient develops heart failure, pulmonary hypertension, congestive heart failure, biventricular failure, they can have biatrial enlargement. So also in aortic valve stenosis. So the P wave is biphasic and has a tall pointed upstroke and then a deep wide negative component in lead V1. So that indicates biatrial abnormality. So this is ECG of a patient with long-standing aortic valve stenosis. You see that patient's rhythm has changed. What has happened? Patient has developed atrial fibrillation. He has developed irregular pulse, irregular heart contractions. And this is atrial fibrillation. Fine fibrillary waves can be seen here. It can be seen in V1. They're not consistent, have no association with the direct association, regular association with the QRS. The QRS also has become slightly broader. So this may be a additional incomplete left middle branch block, which is again an indicator of left ventricular hypertrophy. If you see the complexes, the S waves in V1, the R waves in V5 and V6, they are pretty tall. I'll tell you what are the indices used for calculating left ventricular hypertrophy, but you have to note this. When you note such tall waves, you have to consider a diagnosis of left ventricular hypertrophy. This is in long-standing late aortic stenosis, atrial fibrillation, a kind of a conduction abnormality, that is left middle branch block, and left ventricular hypertrophy. So these are the findings in aortic valve stenosis. So this is what has happened. If you see here, the thickness of the left ventricular muscle has increased, usually about 9 to 11 millimeters. If it is 12 millimeters or more, the septal thickness and the posterior wall thickness in diastole, we call it as left ventricular hypertrophy. So you see tall R waves in one, tall R wave in AVL, deep S waves in V2, V3, V1, and tall R waves again in V5 and V6. The QRS has just become a little broader than normal. 0.010 or 0.11 is the normal QRS duration. If it is wider than that, it constitutes an incomplete middle branch block. So these are some of the criteria that are being used to diagnose left ventricular hypertrophy: Cornell product, Sokolov, Romhill, Estes score. These are all available in any of the standard ECG textbooks. The simplest one is S in V3 plus R in AVL greater than 28 millimeter in men and 20 millimeter in women, suggestive of left ventricular hypertrophy. Then the cure, based on the QRS duration, you have some criteria. Sokolov-Lyon voltage criteria is commonly used. S in V1 plus R in V5 or V6 greater than 35 millimeter, most commonly used criteria indicating left ventricular hypertrophy. Romhill and Estes brought a point scoring system whereby it avoids the fallacies of just calculating an R wave and a S wave, because lead placement may be, if it is not, if the leads are not placed properly, it may give incorrect diagnosis of ventricular hypertrophy. This point score system is supposed to be more reliable for diagnosing left ventricular hypertrophy. So left ventricular hypertrophy by voltage criteria, R in AVL again greater than 11 millimeter. This strain pattern, that is asymmetric ST segment depression and T wave inversions in right-sided leads, the deep S waves in V1 or V2. In the left chest leads, the R wave more than 23 millimeter in V5 or in V6. A leftward shift in the frontal axis to minus 30 degrees in lead 1, and in AVF it is negative, lead 1 is positive, AVF is negative. This is called as left axis deviation, is associated with left ventricular hypertrophy. So using all these criteria, you can consider a diagnosis of pressure overload, which is aortic stenosis comes up as the first diagnosis. Of course, systemic hypertension is much more common, and but you have to always rule out aortic stenosis in a patient when you see that. Any kind of left ventricular outflow tract obstruction, including hypertrophic cardiomyopathy, supravalvular aortic stenosis, coarctation, all these conditions have to be ruled out when you see left ventricular hypertrophy. In volume overload conditions like heart failure, like even in patients with aortic stenosis, when we see them in the end stage, ignored, untreated aortic stenosis of several years duration can produce congestive heart failure when it becomes indistinguishable from other causes of heart failure by ECG alone. Of course, aortic regurgitation, which I mentioned earlier, mixed volume overload and pressure overload can produce identical changes on the ECG, ST depressions and T wave inversions. So this is the last ECG of the day, again showing left ventricular hypertrophy. You can see that there is some left atrial enlargement. The depths of the S waves and the R waves have been denoted here, indicating very tall voltages, which are a reflection of underlying left ventricular hypertrophy. So that summarizes the changes in atrial septal defect and aortic valve disease, which can be diagnosed from the ECG and correlated. Remember, one modality alone, ECG alone, cannot diagnose the underlying condition. You have to correlate it with patient's clinical symptoms, echocardiographic findings to arrive at a perfect diagnosis. But these are the ECG representation or ECG features of the underlying conditions. Thank you all for the patient hearing.
Thank you so much, sir. Thank you for such a wonderful insights that you have shared upon the topic today. And it was a very important topic that we have discussed today. So thank you so much for that. Well, we have received few questions from the participants, and with all your due permission, I would like to put across to you those questions.
Sure.
Yeah, the first question is there a major difference between the arterial blood pressure and left ventricle blood pressure that leads to opening of the aortic valve?
Yeah. If you can recall the hemodynamics of the heart purely works on differences in pressures. The aortic pressures are normally like 120/80, what we measure the systemic blood pressure. The diastolic pressure in the aorta will be about 80. Whereas in the left ventricle, the pressures are like 120/20. The highest left ventricular and diastolic pressure normal is about 12, but up to 20 is tolerable to the patient. So if you see in diastole, there is a gradient of 80 minus 12, which is like 70 or 68. So that is how the aortic valve opens. When the ventricle contracts, the pressure in the left ventricle increases exponentially in the isometric contraction period, and thereby it exceeds the pressure in the aorta, and thereby the left ventricle starts ejecting. So all the chambers in the heart open in a circuit-like manner based on the pressures and the ejections by the respective ventricles.
Thank you so much, sir, for answering this question. We will move to the next question, and we will take up the next question that we have received. The question is, what is the best aortic valve procedure and valve size for a 52 years old female, 87 kg, 163 centimeter with aortic stenosis and 2 centimeter of annular diameter?
Right. For a patient of that age group, the surgical aortic valve replacement is the best therapy as of today, even though transcatheter aortic valve replacement is available. If a patient around 50 to 60 years has severe aortic valve stenosis, symptomatic, and is a good surgical candidate, then you should advise surgical aortic valve replacement. And the selection of the valve is, of course, dependent on the costs and the size of the aortic annulus, and you try to put the largest one which the patient can take. Otherwise, there can be a patient prosthesis mismatch and produce gradients and all that. Since TAVR procedure has come up now, transcatheter aortic valve implantation, people have been implanting valves for younger and younger people and with moderate and even low risk aortic valve stenosis, but the longevity of the valve is still uncertain. And if safe surgical aortic valve replacement can be done, it should be done. In Europe, the criteria is about 65 to 70 years for transcatheter aortic valve replacement. For patients younger than that, if they are good candidates for surgery, you should always advise surgical aortic valve replacement.
Thank you so much, sir, for answering this question. We will take up the next question. We are getting flooded with questions upon this topic from the viewers. So we are taking the next question. And next question is, what is the prognosis after an arterial septal defect closure later in life?
Yeah, this is a very good question. It depends on at what time the ASD is closed. The ideal time for closing an ASD is the school-going age. You should close it by about 3 years of age before the child enters school, ideally. But in the Western countries where surgical mortality has significantly come down, all the aortic defects, all the heart defects, they are trying to close it earlier and earlier so that the structural changes are not reflected in the heart. Because you know that any structural change, any hole, any valve defect, any congenital cyanotic disease can produce irreversible changes in the heart. So the earlier you correct them, the better. In fact, some of the centers recommend as soon as the child is delivered, if a defect is found, to correct it at that time. But in our country, that is not the reality because the mortality of operating on a neonate is quite high. We wait till about 3 years, and if we close it ideally at that time, there should not be much change in the lifespan of that patient because they will not develop any pulmonary hypertension and things like that. If ASD is ignored, especially the moderate to large defects, and we allow the right atrium, right ventricle to dilate and development of pulmonary hypertension, after the development, if you try to close, then it will have some residual pulmonary hypertension. Patient continues to be symptomatic, develops atrial arrhythmias and various sequelae of pulmonary hypertension. So when you diagnose the defect, you should close it as early as possible.
Thank you so much, sir, for answering this question. We will take up the next question. And the next question is, in infective endocarditis, which valvular dysfunction is more likely to be observed?
It depends on which valve is infected. If there is a systemic infection, bloodstream infection, left-sided valves, aortic and mitral commonly. In rheumatic heart disease, if the valves are damaged, the irregular surface and degeneration tends to affect those valves. In right-sided endocarditis, for example, long-standing IV lines, dialysis patients, intravenous drug abusers, it is the right-sided valve, the bicuspid and pulmonary valves which can get affected. So it depends on the clinical setting.
Thank you so much, sir, for answering this question. We will move to the next question that we have received. Like I said, we have been flooding with questions all over. So we will take up the next question. And the next question is, why does ASD cause systolic murmur?
Yeah, the murmur of the ASD is actually not across the defect like we imagine, because the left atrium to right atrium pressure is not much different. It is like 12 and 5. There is a small pressure gradient. It does not produce much of a turbulence. The systolic murmur of ASD is most often due to increased flow across a normal pulmonary valve, or there may be accompanying pulmonary stenosis, which is quite common association, ASD with pulmonary stenosis. That is one thing. The second systolic murmur can occur due to tricuspid regurgitation, which is again a common accompaniment. Patients also might have mitral valve prolapse and mitral regurgitation leading to the AV valve systolic murmurs. So the murmurs are basically arise from the pulmonary valve or the AV valves. Sometimes patient may have an unrelated condition like anemia, which can give rise to systolic murmurs. So these are all the cause of systolic murmurs in a patient with ASD.
Thank you so much, sir. Thank you for answering this question. We'll move to the next question. And the next question is, okay, so this is the last question. And this question is, how does clinically bicuspid aortic valve develop signs and symptoms in diabetic patients?
Oh, it's not much different in diabetic as well as non-diabetic patients. Bicuspid aortic valve disease is extremely common and affects about 2% of the general population. And a majority of the population may live throughout their life without any sequelae. Means they may have a bicuspid valve, but no stenosis or regurgitation. But those symptomatic patients can develop symptomatic aortic stenosis or aortic valve regurgitation at about 44th or 5th decade of life, when it requires treatment. I'm not aware of any differences in diabetic or non-diabetic patients, but of course, if there is a predominant calcification of the bicuspid aortic valve, it may degenerate faster and develop aortic stenosis.
Thank you so much, sir, for answering this question. I said that we would be taking up the last question, but we have received another question. And this is the last question, sir. With all your due permission, if you allow, we can take this last question.
Definitely.
Yeah, so the question is, what are the criteria for restrictive ASD?
A restrictive ASD where the pressure gradient is more than usually the size is usually 3 to 5 millimeters, which constitutes a restrictive shunt, and the shunt is less than 1.3 on calculation by invasive cardiac catheterization. So those are the signs of a restrictive ASD. They are clinically of not much consequence, except that they may produce paradoxical embolism. So that is the only concern in patients with this. But now people are closing PFOs and even small ASDs in patients where there are no other causes of young stroke. And in some patients with migraine, it seems to bring down the episodes of migraine. So there are some indications coming up for closing even these small defects.
Thank you so much, sir. Thank you for answering all the questions. That was the last question for today's session. And at the outset, I would like to thank all the viewers for their ardent participation that they have shown throughout by flooding up our centers with questions. So thank you so much to all of them. And with this, I would like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights with all our viewers. We hope that this will definitely help them in their daily clinical practices. So thank you to all of them. And with all the last comments, sir, we can conclude the session here for today.